I was given the talk of psychosurgery historical overview. I worked at the National Hospital for Neurology and Neurosurgery in London, and I operate in a theater called the Maktoum Theater Suite. Maktoum, as you know, is the very famous family from Emirates, and they donated money a long time ago to have a theater suite at the National Hospital. So the prehistory. So it started long time ago. People were refining the skull to relieve spirits or evil, and for melancholia, and to release demons. And then nothing almost happened until the 19th century. But in the late Middle Ages and up to the 19th century, surgical treatment of mental illness, especially melancholia and so-called hysteria, included thyroidectomy, sterilization, castration, clitoridectomy, and hysterectomy. And funny enough, some of these procedures were considered legitimate by prominent neurologists such as Charcot, Brown-Séquard, Bechtelot, and others. So that was surgery for mental illness, but outside the brain. And then we went back to the brain with the non-stereotactic psychosurgery. And the first documented is Gottlieb Burckhardt, a Swiss psychiatrist who operated few patients by removing part of the cortex for schizophrenia. He operated 6 schizophrenic patients that way. At that time, psychiatrists and pathologists in some countries did also the surgery. But the best known is Egas Moniz, who was a neurologist, as you know, and his neurosurgeon is Almeida Lima, who started with lobotomy or frontal leucotomy, which became very popular. And the portrayals of lobotomy in the popular press between 1935 and 60, documented in this article in the Journal of History of Neuroscience, and they say the press initially used uncritical and sensational reporting styles. So that was the attitude during that period to lobotomy. There is another one who wrote a lot about ethics. It is Moses Maimonides, Ibn Maymun, who was born in Cordoba, studied medicine in Fez in Morocco, moved to Cairo to become the own doctor of Saladin, and died then in Cairo. And he wrote, among other things, Almighty God, do not allow thirst for profit to interfere with my profession. In the sufferer, let me only see the human being. That was Ibn Maymun. But if we go even more before Ibn Maymun, there is a guy called Ishaq ibn Ali al-Rahawi. This is not his picture. This is just to show an Arab doctor. But this guy, he was from northern Syria in Raha, which is about here. This is Turkey, Iraq, Syria. And this Ishaq ibn Ali al-Rahawi, he wrote a book called Adab al-Tabib, which means the ethics of the physician in the 9th century. And he wrote that doctors should be employing good morals, action with sympathy, mercy, gentleness, chastity, courage, generosity, and justice. And he gave these guidelines, what the physician must avoid and beware of, the manners of visitor, the care of remedies by the physician, the dignity of the medical profession, and the examination of physicians. And not only that, he also added the removal of corruption among physicians. And this is the first documented description of a medical peer review process. Ishaq ibn Ali al-Rahawi from northern Syria. I will end with this paper of the latest paper about the ethics of guidelines for DBS, which Bart Nutin and several societies have co-authors. And I will summarize by saying that neurosurgery started with psychiatric surgery in the antiquity. Functional neurosurgery started with psychiatric surgery. Stereotactic lesional neurosurgery started with psychiatric surgery. DBS started with psychiatric and behavioral application. Ethical issues have been debated from the beginning. Those who misused psychiatric surgery in the past were not the neurosurgeons. Some of the self-proclaimed ethicists of today are ignorant of history. Thank you.
I was asked to talk about surgery for psychiatric disorders. I do have a disclosure slide where we, in the development of the work I present, We collaborated with Medtronic. There's a patent. We own a chair, and there are some grants. And in that committee in Belgium, there are psychiatrists from the different university medical centers. In Belgium, it's the northern part and the southern part. Neurosurgeons from the different university medical centers. And by the way, even some private hospitals as well. An ethicist, there are lay people and scientists, and recently, since there is reimbursement now for deep brain stimulation for OCD in Belgium, there are also doctors from the medical insurance, but those doctors are either neurologists or psychiatrists, so they know about the topic. And that committee decides whether the patient is a candidate, yes or no. And if the patient is a candidate, the patient, of course, can still decide for him or herself. And we only do the surgery if the treating psychiatrist agrees, if the family agrees, if the patient agrees, of course, by written and orally. Good. Let's start with OCD. OCD, obsessive compulsive disorder, has as major symptoms intrusive thoughts, which we call obsessions, and compulsions. And so they often go together with ritual behavior, and often you see the symptoms anxiety and depression. And in general, you treat them, the psychiatrist treats them with medication and or, so sometimes a combination of behavioral therapy, cognitive behavioral therapy. There is a small percentage of patients that is not enough helped. And then teams in the world think that there could be a place for surgery. And the surgery could either be lesion, and here you see some examples which are routinely performed worldwide in some centers, but a very limited amount of centers, and usually with little amount of patients. Cingulotomy, capsulotomy, anterior capsulotomy, or subcaudate tractotomy. All these people sat together and wrote a text to define what they think can be done and what cannot be done in neurosurgery for psychiatric disorders. So it means that if I, as a single neurosurgeon, would start doing things at the corner of the street, and I don't follow those guidelines, then those societies can say, we do not stand for that. Of course, if you think those guidelines are not correct, you may be correct, but then please publish them so that society can change its mind. So the question is now, why is everything still experimental or investigational? Well, we have stated in there when it does not become investigational anymore. And that's this: at least 2 blinded, randomized controlled trials, if it is possible, from 2 different groups of researchers for the same target and the same indication, need to be published, both showing an acceptable risk-benefit ratio, which is at least comparable with other existing therapies. So this is just a reasonable demand, but we want to have that limit of safety because of the very sensitive kind of nature of neurosurgery for psychiatric disorders. So this is my last slide. Try to follow those thoughts or create your own thoughts. Please do, but then publish it. There are plenty of opportunities, but proceed cautiously. So thank you for your attention.
For everybody, I will concentrate on the rationale for spinal cord stimulation indication and stress on how to avoid wrong indications. This is to remind our overall experience in neurosurgery for chronic pain. We don't do only surgery. We try to verify that all medical treatment has been properly administered. We also use TENS for pain from peripheral nerve lesions. Spinal cord stimulation can be indicated in the frame of visceral or vascular pain, complex regional pain syndrome, 1 or 2, and of course neuropathic pain. Spinal cord stimulator can be implanted either by percutaneous way, which is a less invasive method, the most used at present time, either by neurosurgeon or by specialists in pain from the anesthesia discipline, or by direct implantation through interlaminar approach, mainly at cervical level. At lower level, percutaneous is the first option. I will not insist on that. What I want to say that we must not implant even nice, sophisticated, very modern electrode if the dorsal column fibers are not functional. And I see doctors forcing themselves to implant very, very nice electrodes, although there is no functional fibers to stimulate in the spinal cord. I want to recall something very trivial also about the appropriate target, which is not so easy to reach. All people involved in the spinal cord stimulation work know that. I take the example of a patient having pain in the upper limb, for instance at the C6 level, due to a peripheral lesion. If the electrode is too lateral, according to midline, because dorsal roots have a threshold lower than dorsal column, you will have evoke paresthesia, evoke pain due to stimulation in the radicular territory, and the patient will consider the technique not effective, not worthwhile, not because stimulation was not effective, but because the side effect of parasite pain in the root opposed to input intensity. On the contrary, if stimulation for pain in the upper limb is put too near the midline, in other words, in the cuneus tract, patient will feel paresthesia in the lower limb, which is not the site of pain, and he will refuse to use. And the stimulation should be here, this was the gracilis for lower limb. Stimulation should be in the cuneus, in between dorsolateral sulcus and gracilis tract, and just above the level of the pain territory, which is not easy, especially in percutaneous method. In lesion due to spinal cord injury or pathology, we must differentiate, which is very important, segmental pain corresponding to segment altered to the infralesional pain. For segmental pain, spinal cord stimulation should be tried. If not effective, we can consider microtracheotomy in very selected cases. And for pain coming from the infralesional territory, if the lesion is incomplete, we can try spinal cord stimulation. If it is complete, no way to have a single result. And for brain, central post-stroke, which is not in the frame of neuropathic pain, in my opinion, it's outside this frame, but classified classically in the frame, we can do motor cortex stimulation, which is not approved by FDA, but this is investigational in the European centers. So spinal cord stimulation is a very nice method, conservative, very effective in patient when indication is properly considered. Thank you for attention.
First of all, I think it is important to keep in mind that in the tradition of understanding epilepsy in epilepsy surgery, you have two different traditions, a North American and a European tradition, which are a little bit diverging on 2 points. One is the value of intraictal versus ictal activities and how much they predict the zone you have to operate. And the second point is about the role of the lesion. The key is the lesion versus the key is the understanding of the time-space pattern of spreading of the discharge with reference to anatomy and lesion. Jasper and the Canadian group was saying that sporadic spikes discharges constitute the most common form of epileptic discharge seen in objectively verified epileptogenic lesion of the cortex, and that's the lesionocentric vision of epilepsy. When you have a lesion, the epilepsy is around the lesion. In the spreading of the methodology of MEG in epilepsy surgery, one of the main limitations is to understand how much the MEG, which is usually recording only the intraictal activity. This is difficult to have a patient in MEG who is seizing. So usually, traditionally, you have only access to intraictal activity in MEG. So all the question about the role, potential role of MEG in epilepsy surgery is to know how much you can trust the localizing value of intraictal activity recorded in MEG to operate your patient. And what we are doing systematically in Marseille is to try to analyze scalp EEG, SEEG, depth electrode EEG, and MEG together to try to interrogate this localizing value of MEG activities. I'm not saying that it is mandatory to use MEG with SEEG. I'm saying that in the phase of evaluation of the limits of virtue, advantages, and limit of MEG, we are systematically comparing the data. We are taking the opportunity of those patients who have SEEG to try to understand better MEG. So as conclusion, I will say that MEG brings a measure of spatiotemporal basic features of the human epileptogenic zone, which is totally non-invasive and which is turning out in our experience to be very precious. Signal analysis tools should utilize such a capability rather than refining the dipole fitting. I mean that you have to be extremely cautious about the subjectivity in the sense that you have to know about what are the a priori which are injected in the algorithm which are used for determining the localization solution. The underlying issue is to determine whether or not the intraictal paroxysmal event contain a print of the epileptogenic process to be specially developed during seizures. You have to always have in mind this question: is what I am observing intraictally really representing what is occurring when there is a seizure? In other words, if I remove this intraictal area I'm seeing in the MEG, would this lead to the cure of the patient? Ictal MEG is very useful, especially in reoperation assessment. Methods of analysis of the component of the surface spike should be developed to take account of the network character of the epileptogenic process in drug-resistant epilepsy. There is a clear interest of a combination of high-resolution EEG and MEG in our experience in the non-invasive pre-surgical assessment. MEG, in our experience, is useful investigation, particularly in patients with negative MRI. MEG is useful, especially in a tight dipole cluster. I mean that when you do a EEG, you see that you have a tight intraictal focus on the EEG. You know that on the MEG, you will have information. The spatial detection sensitivity of MEG is higher than the one of the EEG. There is a complementary role of EEG and MEG, and we think it is good to perform simultaneously EEG and MEG recording, MEG and depth recording, EEG, MEG and depth recording, if we want to know more, and in the future to be able to know what are the limits and when MEG is reliable or not. Thank you very much for your attention.
So we have a first case, which is one of mine. is a female patient, rather young patient, who in medical history showed to have no head trauma so far, febrile seizures or CNS infection, none of these. She had the first seizure at the age of 14, which were complex partial seizures, and a first generalized tonico-clonic seizure at the age of 15. At MR imaging, there was a right occipital arachnoid cyst seen, for which surgery had been done already, but was not accompanied by a decrease in seizure frequency. She had a status epilepticus in 2008, and her current anti-epileptic drugs consisted of Keppra, Lamictal, and Topamax. And in the past, she had already tried others. The semiology of these complex partial seizures were an aura of nausea, followed by a dream sensation. During seizure, the patient was not responding to interaction, and sometimes orobuccal automatisms were seen. So my question to you is, do you have already a clue from this semiology where seizures could have their focus? What we usually do is repeating the imaging, because it may happen that in other centers which are not devoted to epilepsy surgery, it may be that a sort of screening is done, but not with all necessary sequences. And it may be very useful to have these sequences done, as for instance the flare or whatever. So this was the first step, to repeat imaging, and it may be very subtle, but we saw some hyperintensities on flare sequence around the right occipital horn and in the left thalamus, which is tiny and very subtle.
Since she was 6 years old, so that's a 13-year seizure history. You see the semiology. There's no aura. She just has loss of consciousness, and then she has hypermotor bilateral jerks of arms and legs. Hypermotor means very intense. Yeah? 1 to 4 a day. And she has tried virtually every drug. You see the list of drugs. Neurological finding is normal, so we have no hint from the neurology what's going on. Okay, she's 19 years old. So we do the usual EEG, and we have a bilateral frontal seizure onset, which is very quickly propagating to the supplementary motor area, which is premotor. The extensive neuropsychological testing gives no hint. Sometimes the neuropsychological testing tells you it's a frontal lobe effect or it's a left temporal lobe problem. In this case, no indication, no hint. So we have bilateral frontal seizure onset. Okay, so we do other non-invasive steps like PET and SPECT, and you see the result. Not very helpful. In the PET, it's on the right, temporomesial, temporopolar, but also temporoparietal hypometabolism. Very widespread hypometabolism. And the SPECT, which should show you the origin where the seizures start, shows left frontodorsal hyperperfusion with extension to the left insula. So the EEG bilateral, PET is right temporal, temporoparietal, and the SPECT is left frontodorsal. Hallelujah, what can we do? This shows you, illustrates that epilepsy surgery can be very complicated. And you need a very good epileptologist, otherwise you are lost. Now this lady had a long history. Here you see preoperative MRI scans. From 1995 to 2008, she had this list of MRI scans. And as I mentioned, in this period of time, there was a huge development in the power of MRI to detect lesions. For example, the FLAIR imaging sequence was not introduced until about 1995. And FLAIR is the sequence that shows you hippocampal sclerosis best. And I mentioned in the morning, in the early 90s, the detection rate of hippocampal sclerosis in our service was only about 20%, because MRI technology was not so advanced. Now it's 90 to 95%. Okay, so if you see this list of MRIs, it's not only a list of failures. It has to do with the fact that we are a specialized epilepsy surgery center. Others are normal MRI practices. They do lumbar spines, 15 a day, brain scans, 20 a day, 15 a day, and they have no special knowledge about epilepsy surgery and the pathology of epilepsy surgery. Okay? So usually we require an MRI with a special protocol for epilepsy.